Hi, I'm Dr. Mark Studin, and welcome to today's session, and it's an exciting one. But first, I'd like to thank ChiroSecure for helping create the forum to get this information to you. And today we're going to talk a lot about the mechanism of the chiropractic spinal adjustment. And believe it or not, there's so much confusion out there about what is it? Is there bone on nerve? How does it work? We're going to talk a lot about subluxation, or what I call a pathoneurobiomechanical lesion. There's a lot of things about what we do to get to understand. And believe it or not, when you're dealing with collaborative physicians, primary care doctors, specialists, orthos, neurosurgeons, pain management, by you understanding this, also helps you in the referral process. It's critically important. If you're dealing with lawyers, it matters also, because on the witness stand or in depositions, chiropractors are being asked, how does a chiropractic adjustment work? What is it you're diagnosing? And you need to understand these things. So we're going to really delve into this, not a lot, because this is not going to be completely handled in a half an hour. And I want to ensure that you don't practice what I call soundbite chiropractic. In other words, you understand a soundbite and you know 10%, but you profess to know 200%. I call that the old Chiro one step, two step. So you need real education behind that. All right, let's go to the slides and or the article actually. And actually, we're going to discuss an article today. And this particular article is on the U.S. Chiropractic Directory. And I urge you all to go there. And in the U.S. Chiropractic Directory, if you look along the top ribbon, there's research, case reports, and medical legal white papers. And it's all free. Unlike other folks in our industry who I think are demented, to give you pro chiropractic information, they make you pay for it. Well, guess what? This is all free. And I want you to know that we've had 21,502,531. Let's refresh the page. 541 now since the last 4 minutes. There were 10 hits. So this is a real number since 2012. This also probably is the most visited website in the chiropractic industry. So it's just so important that everyone has this information. Everyone understands it. And I just posted these two articles yesterday, and each of them have gotten about 300 hits in a day. So let's go to the article we're going to be discussing. And it's called, this is the Chiropractic Spinal Adjustment Mechanism Explained. Chiropractic Spinal Adjustments Increases Facet Gapping, and Functional Outcomes. And I've done that with Dr. Capaferi in conjunction with him. Now, this was also just published, actually, it's being published this month in Dynamic Chiropractic, so that you can look it up there if you choose. But what this says, and by the way, you're going to see me. I'm a nerd. I'm sitting in front of 4 screens. When I'm looking at the screen I'm presenting is here. When I'm looking at the words and scrolling and using my pointer, I'm looking this way, so you're going to see a little bit of this side of my face. It says the prevalence of neck pain is significant in a general population, affects almost half the population in any 12-month period, and a lifetime prevalence is 70%. So we're talking something that's an epidemic proportion. I work with many primary care medical doctors, many of them, and I consult for a bunch of them. I work with emergency departments and emergency rooms, and I could tell you that the 5th most prevalent diagnoses, number 5, is back pain, musculoskeletal, 5th most. And they tell me that there's one guy told me yesterday in a suburb of New York City, told me that he could actually refer 20 cases a day into a chiropractor's office, but he doesn't fully understand the mechanisms and how this happens. So because of that lack of knowledge, he refers to PT. So stuff like this has a very big level of applicability to fully understand it. This article is focused on the effects of the chiropractic spinal adjustment and cervical spine outcomes regarding pain and biomechanical functional outcomes. Here's the key, folks. Everything is about spinal biomechanics. It's not about, oh, I'm taking a bone off a nerve, even though there is bone on a nerve, and it's not the nerve root. It's not about your technique. Oh, I did a P to A. I'm an Atlas orthogonal technique specialist. No one cares. The second you talk about your technique, you've lost everybody. You've lost the game. It's not about that. Remember this one word, management. It's about managing your case. How do you manage your case? How do you diagnose your case? Because chiropractic medicine is diagnostic heavy and treatment short, and chiropractic is the converse. It's diagnostic short and treatment heavy. So what we're going to do is meld those two things today and give you information. So when considering intervertebral kinematics, specifically joint movement and residual gapping, manipulation is considered an effective treatment for neck pain. Now, this is all based upon taking from literature, and I have all the references down below. I don't like using the word manipulation. I don't like it, and here's why. The problem with the generalized descriptor manipulation in a high velocity, low amplitude, quick thrust conflates providers as physical therapists, osteopaths, and chiropractors all utilize similar descriptions in treatment. This is confusing when considering care paths and often misleading. The medical doctor said to me, the primary care, well, you all manipulate the spine. What difference does it make who I send it to? We don't all manipulate the spine equally. A chiropractor renders a chiropractic spinal adjustment. A physical therapist does level 1, 2, 3, or 4 joint mobilizations. And the evidence in the literature is clear. When physical therapy is the first provider, there's upwards of a 313% incident of additional disability versus if a chiropractor is the first person treating it. Now, I love physical therapy. It's wonderful. But for spine, not as the first provider. So when I explained that to the medical provider, and I showed him the research article, because it's not about a soundbite. It's about having full understanding of this. He goes, his eyes like bugged out of his head. Oh my goodness gracious. I said, we do not do joint mobilizations. We do a high velocity, low amplitude thrust called a spinal chiropractic adjustment. It matters tremendously your language. It matters tremendously in how you communicate. And it separates you from the pack. We do not do what they do. Not at all. And I'm not saying what they do is bad. It's just for spine. This is about functional outcomes. Functional outcomes, functional outcomes. Here it is in a nutshell. That's the winner. Because you want to increase function. And when you increase function, and let me rephrase that, normalize function or create homeostasis. Now, if you look at medicine, and by the way, medicine's going to validate chiropractic. We're not going to validate ourselves. It's going to happen in the research world, in medical academia. It's already starting. I want to impress the medical community. How come? Well, we've been in this game since 1895. So that's 127 years. We've been hovering for decades at around 7% utilization of the population. That's it. Medicine sees probably 99% of the population. Do I want to keep doing the same thing and fighting for that 7% to get it to 8%? Or do I want to tap in to this primary care's 20 a day that he could refer? You know, it's incredible. The number of people that could be in chiropractic offices that need to be, that are being mismanaged. So when you look at biomechanical functional outcomes, when you look at medicine, for instance, when you're treating a high blood pressure patient, do they ever say, I'm going to fix your high blood pressure, I'm going to cure your high blood pressure, or diabetes? The same. No, we're going to manage it. How long? For a lifetime. A lifetime. And it's reality, and life expectancies have increased. And you know what? It's okay. I mean, there's a lot of people making a lot of money, but there's a lot of people getting well and not suffering. So when we manage cases, it's very, very different. And here's the key. When we look at biomechanics, if in fact a vertebra is in the wrong position, we're going to talk about how it gets in the wrong position in a moment. If a vertebra is in a wrong position over a period of time, let me make sure I'm not doing this later on. No. Okay. In a long period of time, the piezoelectric effect comes into play, and then the bone starts to remodel. You're going to create first, and I'm not going to go into the mechanism. Bone spurs. It's going to leach calcium from the adjacent vertebra into the anterior, posterior, and longitudinal ligaments. It's going to calcify. It's going to remodel the bone. Once that bone has been remodeled, it's no longer a perfect square. Not that it's or a rectangle or whatever shape it should be, but it's going to be not a perfect square. So now the vertebra is going to be lined up aberrantly, constantly putting pressure on the facets. As a result of that, you're never going to be able to make a full correction. If in fact you get the person under care early, provided there's no damage to the ligaments, which is a conversation for a whole different time, you can hopefully make as much correction as possible. But once that vertebra starts to remodel and you're off even 1 degree, that spine will never stay in the right spot. So now you're managing that spine for that person's lifetime. And I'm not saying you're managing their pain, you're managing their biomechanical abnormal function. The original reporting of joint gapping by Kramer and more recent reporting by Anders in 2018 utilized the chiropractic spinal adjustment model by an experienced chiropractor. Therefore, this article will be focused on, will be focused on chiropractic to prevent confusion when considering a care path based on an evidence-based model. It's in the literature. Kramer reported in 2002, and again it was confirmed in 2018 by Anders using chiropractic only, the thrust given to chiropractic procedure had the effect of increasing the gapping of the zygapophyseal joint, the facet joint. The average, so you're delivering a high velocity thrust. When you do that in the facet joint, there is a meniscoid or a plica. It's a spacer. And when you have a macro trauma, or repetitive micro traumas, car accidents, sports injuries, falls, or repetitive micro traumas, walking with high heels that cause your hip to tilt, anything which causes repetitive trauma. That spacer dislodges. It's called the buckling effect. It buckles. And the spacer dislodges, and the facets now are aberrantly positioned and they approximate. Especially if it's a high velocity or a macro trauma like a car accident or sports injuries, it's going to overstretch that joint ligament capsule. And in those ligaments are nociceptors, mechanoreceptors, which are your Pacinian corpuscles, which are your stretch receptors, your Ruffini corpuscles, which are your crimp receptors, your Golgi ligament organs, where it sends information also to the lateral horn, and the nociceptors. So in the joint capsule, there's mechanoreceptors and nociceptors. A myriad of information is going into the central nervous system. At the facet level, you have nociceptors that line the facet. So when that joint, that gapping goes out of place, it does that, and now it's firing into the lateral horn. Why does it do that? It does that because when everything's out of position, it's bringing you off plumb biomechanically, so the body wants to plummet. So what's happening is it goes up to the brain. Everything is from the brain, everything. Then the brain shoots down information. You got mechanoreceptors all over the body, and it knows where it needs to be, and it has to create an antalgia. An antalgia is correcting to get you biomechanically plumb. That's what antalgia is. Leaning from the pain is one way, but it's also creating other issues. So the brain now sends efferently information to the muscles through the motor cortex, and it says spasm. If you have a problem in the lumbar spine, which is taking you 2 degrees right, it's going to pull your cervical and thoracic spine to try to put curves in there to get you plumb where you want to get your glabella, your episternal notch, and your pubic symphysis in line. So the body's going to try to plummet. So what this says is the average difference between control subjects that received the chiropractic adjustment and remained in the side posture position was 1.33 millimeters, and a difference of 0.71 found in the side posture group. So what they said is the facet gap increased 0.9 to 0.4 millimeters. and they retook imaging 20 minutes later, and it persisted. They didn't do after that. So what they're saying is those little spacers, those meniscoids, those plicas, similar name, get reseated. Unfortunately, muscles are patterned sometimes, and it goes back out. Or the ligaments are overstretched, and it goes back out, and it needs to be reseated. But once you put that meniscoid back in, it now separates. It's a spacer. Those facets, and it's no longer firing. You're relaxing that joint capsule. It's no longer firing. And the whole rest of the body starts to plumb, and it actually decreases pain in all different areas of the body, in disparate areas, as the literature says. Physical therapy doesn't do that. Osteopathy doesn't do that. It does joint mobilization, stretching, gliding. It doesn't deliver that high velocity thrust to create that gapping. The evidence 16 years apart is consistent with the most current articles validating biomechanical changes as a direct result of a chiropractic spinal adjustment. But they also reported in 2018 the results suggest that clinical and functional improvement after a chiropractic spinal adjustment may occur as a result of small increases of intervertebral range of motion across multiple segments. So what they're saying is the study demonstrates the feasibility in characterizing the real-time manual input and biological response when you're adjusting the spine in the cervical area or in the lumbar area for cervical or cervical for lumbar. It helps normalize the entire spine. Beyond post-MRI, which is unrealistic in clinical practice due to cost, there are algorithms based on X-ray to help diagnose these changes and the normalization of the spine. Museng in 2022 reported the study of subsequent subject-specific spinal loading could help further the understanding of cervical spine biomechanics, degenerative mechanism, and complications. This is what we discussed. Aberrant biomechanics causes degeneration, the piezoelectric effect, and complications from that because it remodels the bone. We also know, despite the political rhetoric, that diagnostic X-ray is safe and has no carcinogenic effect. X-ray does not cause cancer. X-rays are safe. Tubiana in 2009 reported, among humans, there is no evidence of a carcinogenic effect for acute radiation in a diagnostic X-ray as we use. And the numbers, and I'm just going to give this to you briefly, they found that it takes 100 millisieverts, that's a unit of radiation, 100 millisieverts in one setting, because it's not cumulative, to have less than 1 in 100,000 aberrant radiation effects. Less than 1 in 100,000. But still, you don't want to be that 1 in 100,000. 100 millisieverts. A lumbar X-ray is 5. Let me just get the numbers down exactly. I'm using a calculator. It's approximately 1.79 millisieverts. One lumbar X-ray is 1.79 millisieverts. You would have to do 56 lumbar X-rays at one time to have any evidence of less than 1 in 100,000. I've been in this game 41 years. I don't know any chiropractor ever who took 56 X-rays at once. I mean, that's kind of crazy. So it just backs up. Diagnostic X-rays have virtually no negative adverse health sequelae based upon this and the totality of everything in the literature. But there is technology, that renders pre and post biomechanics based upon X-ray and ligament pathology to demonstratively document changes. It renders demonstrative visual pattern. Now, we use a piece of technology called Symverta, Symverta. It's an X-ray digitizing platform and does a myriad of things. And what it's showing, and by the way, today the algorithm has been changed, but what this says, it's a flexion extension X-ray, cervical, lumbar. But what it does is it measures either translation, forward and back, or positive X movement, and positive, or theta X actually, which is forward rotation, or negative theta, backwards rotation, and it's measuring the movements, and there are thresholds. So what this is saying is anytime a vertebra moves more than 0.6 millimeters, and by the way, that's now changing to 0.78 plus or minus 0.22 based upon more recent evidence in the literature, there is ligamentous pathology. And it's going to, and look at this. I mean, where would you adjust this patient? I mean, this is just kind of easy. There's pathology at C2, C3, not so much in C4 is normal. C5 is a tiny bit, I'm not going to really count that, but C6 and C7. And there are other views that you can see from this technology to tell you whether you adjust inferior to superior or left to right. So it's telling you exactly where these issues are and these problems are. And when I go to the medical doctor and I sit with the neurosurgeon, the orthosurgeon, the primary, and they say, well, it's only non-specific back pain. I said, non-specific? Yeah, no fracture, no tumor, infection, no herniation. They can't see it and find it. When I show them this technology, their eyes bug out of their head. I said, you see, and what I share with them is I say, doctor, I appreciate that there is no anatomical pathology for you to treat, but there is biomechanical pathology and there is connective tissue pathology, which is secondary strain sprain. And that's exactly what this is. There's significant tearing and subfailures. And I'm not going to get into that right now. We don't have the time. But when I show this to them, I say, it's very specific, and here's where the problem is. Chiropractic needs to evolve with technology. It needs to evolve with the evidence in the literature. It needs to evolve in how we communicate, and it must be demonstrative. When I show this to the medical doctors, surgeons now are saying, I need this on every patient. Because if there is, this is 2.5, if there is a significant amount of translation, I can't use an artificial disc if I'm doing a discectomy. It's going to change how I treat the patient. They want us to digitize their images and evaluate them. And then when they're done with surgery, get them back in to treat the adjacent areas, because if not, you're going to get adjacent segment degeneration, which happens in almost every one. And there's a 22% of resurgical incident because of adjacent issues. So it just works. There's so much out there that's changing everything. In conclusion, folks, Anders concluded the results demonstrate that target and adjacent motion segments undergo facet joint gapping during manipulation, which is a chiropractic spinal adjustment, and that intervertebral range of motion is increased in all three planes of motion after adjusting the patient. The results suggest that clinical and functional improvements after a chiropractic spinal adjustment may occur as a result of small increases in intervertebral range of motion across multiple motion segments by putting those plicas or meniscoids in. The study demonstrates the ability of characterizing in real time the manual input and biological response that compromise cervical manipulation, including clinician applied force, facet gapping, and increased intervertebral range of motion. So we can go on and on and on. But analytical tools like Symverta can assess the location of facet compromise for acute treatment, for accurate treatment planning. Folks, it creates an accurate treatment plan. We're starting to see carriers push back in lawsuits, and they call them predetermined treatment plans. Everyone gets the same treatment, everybody. Well, guess what? And I've seen that in a huge amount of cases. Well, guess what? Here it is right here. I'm adjusting the patient here, 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 and here. There's no predetermined treatment plan. And I'm going to redo this in some instances in almost every reeval, which is every month, because there's no negative x-ray effect. And I'm going to see where it gets better and change my treatment plan. And then when it stabilizes, I'm going to MMI my patient. It's just easy. It's just easy. We have doctors all around the country doing that. And it's evidence-based, let me rephrase that, demonstrative evidence-based practice. It makes it simple. Are you changing what you do? No. Are you changing how you adjust your patient? No. All you're changing is where and when to stop, because the body will tell you. And when you've reached MMI, I'm going to still treat the patient if the bone's remodeled. And that's going to tell us a whole lot, because I'm going to still treat the patient if the bone's remodeled, maybe for their lifetime because they need to be managed, but now not an acute or reconstructive setting. But that's a conversation for another time. So folks, wow, so much to unpack in such a short amount of time. I'd like to thank you so much. Again, ChiroSecure, thank you for giving us the platform. Mike Misko will be here next week to share with you a whole lot of really cool information. And I'll see you next time. Thanks and have a great day.